I've had my ups and my downs.
Phelps with 10 meters left. Freeman is too good. The crowd roaring. Freeman wins gold.
I think it's an absolutely breakthrough experience.
Welcome to the Physical Performance Show, the show designed to inspire the pursuit of your physical best performance. I'm your host, Brad Beer. Listen in as we delve into how the world's top physical performers achieve their success, as well as the highs, the lows, and the journey of getting there. Let's get ready, set, let's go. Welcome to another episode of the Physical Performance Show, brought to you by the Gold Coast Marathon and Pogo Physio. I hope you've been having a great week, and I trust that you've been enjoying pursuing your physical best. On today's episode, I share a conversation with you that I had with Dr. Christian Barton. This is an expert edition, and today we speak about all manners of things relating to patellofemoral pain, or better known as kneecap pain. Patellofemoral pain or kneecap pain is a huge problem for society, with up to 1 in 10 males suffering from patellofemoral or kneecap pain and up to 1 in 5 females across their lifespan. It's certainly very prevalent in the active population, which is obviously a lot of the listeners of the Physical Performance Show. It's certainly something that I have struggled with myself over the years with my running and triathlon activities. So given my keen interest in this subject from my own personal experiences with long-standing patellofemoral pain and the high prevalence and incidence of it in society, it was with great interest that I chased down Dr. Christian Barton to share around this today in this expert edition. By way of bio, Dr. Christian Barton is a physiotherapist who graduated with first-class honours from Charles Sturt University in 2005. From there, Dr. Chris went on to complete his PhD focusing on patellofemoral pain, biomechanics and foot orthosis in 2010. Dr. Barton's broad research disciplines of biomechanics, running-related injury, knee pathology, tendinopathy and rehabilitation, with a particular focus on what's known as research translation. Dr. Barton has published well over 40 papers in sports medicine, rehabilitation and biomechanics journals. Alongside this, Dr. Barton is also an associate editor for the acclaimed British Journal of Sports Medicine. More recently, Dr. Barton was one of the masterminds behind the TREK, Translating Research and Evidence into Knowledge, a website and an online forum to help practitioners worldwide do just that, take the literature, the science, and disseminate that into the clinical landscape, ultimately for the benefits of the public and patients receiving healthcare. During today's conversation, Dr. Barton shares around the key concepts that will help you better manage your kneecap pain if you are suffering from it, or be aware of it if you do suffer from it, or pass this on if you know someone suffering from kneecap pain. We talk about load management, exercise prescription, which exercises work best, the number of sets, reps, etc., education and what it is that patients need to know about this condition, exercise progression, the importance of being adaptable and patient, how to monitor the irritability of your kneecap pain, what the evidence says works regarding best treatments for kneecap pain. And we talk about adjunctive therapies such as PRP. Dr. Barton jumped online for a follow-up conversation after our initial conversation to answer the question about stretching and the role that it plays in the management and the treatment of kneecap pain. So jump in for this expert edition. If you are a kneecap pain sufferer, patellofemoral pain sufferer, I hope that this conversation with Dr. Christian Barton really helps you. Here is Dr. Christian Barton with an expert edition. So, Christian, we've had several attempts just around schedules to try and align this. So it's great to finally have you on the call from, I think you might be at La Trobe University today.
Yeah, no, correct. No, thanks very much for having me, Brad. And sorry I've been hard to track down and get a hold of.
Well, I don't think you owe me an apology, Christian. You're out there doing some great work in the world of many things, particularly patellofemoral pain or knee-related pain, anterior knee pain, which we want to really deep dive on today. So, Christian, just a little bit about you to start with. Obviously, you've got your PhD studies, but take us right back. What took you into the field of physiotherapy, and then what took you into the field of research and this particular interest in your expertise area of patellofemoral pain and running-related injuries?
Yeah, so I think probably like a lot of physios who go into the field and the profession, I had a sports injury when I was a kid, adolescent, and saw a physio, and it was an ankle sprain, and got some good treatment that helped me get back to playing sport and get back to doing the things I liked. And I thought this could be a fun job, and I was probably keen to get into the sports-related field and thinking, well, if I can't be a professional sports person, maybe I can at least work with them. I was clearly never going to be good enough to be a professional sports person. But that was what originally got me started, and then obviously do your research degree, and during that I've always been interested in trying to challenge myself, so did an honours project as part of that, looking at the foot and how it links to biomechanics. And then when I started my clinical practice, one of the conditions I found quite challenging to treat was patellofemoral pain, and I ended up signing up very early after a year and a half of clinical practice to do a PhD in trying to understand that as a condition better, and trying to, in particular with that research, understand why foot orthosis may or may not help those individuals.
And so, Christian, you mentioned that you were challenged by treating patellofemoral pain. What did you find challenging in that stage of your career treating it?
I think I guess I'd learnt things at university and was told the way I should be treating these patients, and I would do what I was told to do, and sometimes it would be highly effective and other times it would be completely ineffective. And on reflection, you have a bit more of an understanding now, and I'm sure we can talk about that a little bit later. So it was probably, I guess, it's a condition that's the most common running injury that we see, and it's in a group of people who are really active and often really motivated in a certain subpopulation, and that is actually what makes it quite a challenging condition to treat, because we'll talk more about this later, but load management is probably the most important thing with these patients, and if you don't get that right, then you're not going to do very well, and I was probably quite poor at managing that in the early stages of my career, and so I was trying to look for answers about how I could manage these patients better. Well,
Christian, I must declare my own self-interest in the topic, and that is that I've had patellofemoral problems over my years of triathlon and running, so I am deeply intrigued by how it responds and doesn't respond. But just to put listeners in perspective, Christian, with your week, you split your attention across many professional projects. You're clinical director at Complete Sports Care in Hawthorn, Victoria, with one of our previous expert edition guests, Dr Peter Maliaris. You've also involved with La Trobe University heavily, and now the Trek project. But can you just give listeners a little bit of perspective of what a week in Dr Christian Barton's life looks like professionally?
Yeah, so my weeks are quite varying. I spend maybe a day to 2 days a week treating patients, and primarily their lower limb injuries, so different leg pathologies, and that could be patellofemoral pain or other knee injuries or tendinopathies. Maybe half of them are running related, but also treat a lot of sedentary patients as well. And when I'm at La Trobe University, I'm there a few days a week, and typically my research revolves around different clinical trials for knee pathologies, and in particular now patellofemoral pain and knee osteoarthritis. And also I have a big focus on knowledge translation. So you mentioned Trek, which is a not-for-profit initiative which we started up more recently to try and get information out to the people who really need it. So rather than research being stuck behind a paywall of a journal, it's trying to get information into formats that a clinician would engage with and a patient might engage with. So thinking about how we can create not just podcasts like we're doing here, but also different animation videos and webinars. Also thinking about engaging resources like infographics and even blogs, but making sure these are not written by people trying to sell something. They're actually written and created by people who have the key knowledge that needs to get to the end user, being the patients and the health practitioners managing these conditions. So that's my main focus, is around knowledge translation with my research.
Well, certainly, Christian, I've been one of the beneficiaries of your good work and also the early work of Trek, so thank you. Christian, let's throw into patellofemoral pain. We professionally commonly refer to it as that. But can you just take us right back, tell us what it is, and if someone's out there listening in and they know that, or they perceive that they may have some patellofemoral related pain, what is it and where does the pain come from, Christian?
Yeah, so essentially patellofemoral pain is just a fancy Latin word for kneecap pain, and I think that's something where we immediately go wrong with patients. We should actually call it for what it is, and it's kneecap pain. We don't need to use our fancy medical degree jargon. And essentially the pain is around or behind the kneecap is typically what it's associated with. And that pain can be aggravated by tasks that load the knee, in particular running and jumping, squatting. Those types of activities are the ones that will typically irritate symptoms, going up and down stairs. And a lot of people who have quite an irritated joint, it can actually be quite sore with prolonged sitting as well. So if they're sitting for a long time, and we typically call that moviegoer's sign.
Sure. And I'm glad you called it kneecap pain or referred to it as kneecap pain. That's typically how I like to refer to it, to take all the mystique out of it as well. So that's great. So, Christian, in terms of the pain generators, I mean, a tissue-based approach, I found as an undergraduate this left more questions unanswered than answered about where the pain is generated from. In terms of a tissue-based approach, where does the pain typically come from? Where can it come from?
Yeah, so if we're brutally honest, we have no idea where the pain comes from. If we talk about a group that I work with the International Patellofemoral Research Network, we have a conference every 2 years where we get together and share our latest research in the area. And at the end of it, we write consensus statements about what we know, what we need to continue to learn, and maybe some directions for clinicians and patients, etc., about how to manage this common condition. And we never, ever come up with a consensus about which tissues may or may not be involved. So there's lots of theoretical concepts around it potentially being subchondral bone, being stressed through altered patellofemoral joint stress and tracking. You could consider potentially also synovial and synovitis. You could consider strain on retinaculum that control the joint and ligaments that control the joint. There's another structure in the front of the knee called the infrapatellar fat pad, and that's a highly innervated structure, and one of the theoretical concepts is that may actually be the thing that's driving this pain around the kneecap. But if I'm brutally honest, we really don't know what the actual tissue source is. And the additional thing for us to consider is pain is not as simple as a pain nerve ending. In fact, those don't really exist, and pain is not a sign of damage. It's actually a sign that your brain is perceiving something as dangerous. And as a result of that, there's a lot of non-physical and non-tissue things that we need to think about. So things like our mood and how much we're sleeping, and a lot of psychological factors can also influence pain. So it's a bit more complex than the tissue theories we're taught at university.
Yeah, sure. And if you have someone, say, with persistent patellofemoral pain, kneecap pain, Christian, with imaging that is brought in, often these are recalcitrant conditions that people just struggle with over, protracted periods of time. And they say have an MRI which shows something like a trochlear groove, in the bottom of the femur or the thigh bone, like a lesion, and bone marrow fluid around it and some edema and things. Like, it'd be hard pressed to say that's not likely a bit of the pain generator, wouldn't we?
So if we think about pathology based on imaging, in terms of what we see on an image like an MRI, there is some relationship between bone edema and pain when we look at the knee. And we see that consistently even in back pain, where actually a lot of the findings on MRI are not going to be related to pain, but bone edema can be. But it's not a one-to-one relationship, as in it's not linear. And if there's lots of bone edema, that doesn't mean lots of pain. And if there's no bone edema, that doesn't mean no pain. So there's a relationship, but it's not necessarily strong. You'll see a lot of other things on an MRI. You might see other various cartilage lesions. You might see what's commonly termed chondromalacia patella, where there's some lesions at different segments of the patellofemoral joint or the kneecap and the thigh. What we do know, though, based on both X-ray studies and MRI studies, is the levels of some of these findings in people with and without pain are actually quite similar. So we can grab a random sample of people off the street without pain and a random sample of people off the street with pain, and if we compare the MRI findings or X-ray findings, they'll on average look the same. So I don't think we should be too focused on what we're seeing, but certainly bone edema might be something to consider.
No, that's great. Thanks, Christian. Christian, how prevalent is it? You mentioned it's one of the most common running injuries or injuries of the anterior or front part of the knee, but how common is it? Any stats that you've got around that?
Yeah, so there's not great information on prevalence, but there is a few studies which we can kind of pull together and give an estimate of how prevalent the condition is. So at any point in time, the estimates from a number of studies are that about 1 in 14 people, so about 7% of the population would have patellofemoral pain or kneecap pain, and this seems to be more common in females compared to males, so you're probably looking at maybe up to 1 in 5 for males and maybe up to 1 in 5 for females and 1 in 10 for males. One of the things that we do see is that there's certainly a spike in the incidence of patellofemoral pain or kneecap pain when people become more active. So when we look at cohorts who would, say, enter a military program and do basic training or a start to run program, we will see much higher incidence, upwards of 30 or 35% in these populations. Certainly within the setting that I work, probably around 25 to 40% of the knee injuries that we see would be related to kneecap pain or patellofemoral pain.
Yeah, so very common. I certainly know in my clinical practice, it's treating a lot of runners. It's a weekly thing that I'm looking at. And Christian, I know at one of your international patellofemoral pain research symposiums that I believe happen every 2 years, the recent one being held on the Gold Coast here in Australia in 2017, but there was a slide that I believe went up at some point, which was a picture of, I think, a gentleman sitting on a couch, and the meme or the caption was no correlation between number of hours of Netflix and your knee pain. So it really tends to be a condition of active people.
Yeah, I think that certainly can be the case. That's Michael Raffler's side, a good friend of mine and a colleague who we do a lot of research around how to educate patients. But one of the things about sedentary behaviour is actually we do see patellofemoral pain develop in sedentary populations, and it typically develops later in life where perhaps they become a bit more overweight, and then stairs and just general walking can become problematic for them because they don't have the capacity in their tissues and they lose a lot of strength, etc. And I think if we look at what's driving the condition in most younger people and active people, it's more so how much running they're doing or how much exercise they're doing. So there's probably a much stronger relationship between that and development of pain and persistence of pain. But in saying that, if we think about, well, is there a correlation between Netflix hours or sitting on the couch and watching TV? It's probably more so related to previous Netflix hours. So if you've spent 10 years sitting on the couch watching Netflix and then you suddenly decide that you want to take up running and you do it too quickly, there's a really strong chance that you'll develop patellofemoral pain and you'll develop it very quickly. So I think we need to be careful about trying to keep consistent exercise happening. So we see a lot of people just develop pain because of this boom bust cycle. They do nothing, then they do lots, and then they do nothing, and this is the problem, as opposed to a consistent level of activity, which is actually good for our cartilage and good for our joints.
You're listening to Dr Christian Barton, postdoctoral physiotherapist, share around all things relating to kneecap pain. Support for today's show comes from the Gold Coast Marathon. Just like the Physical Performance Show, the Gold Coast Marathon encourages runners of all ages and abilities to push their boundaries and strive to complete a personal challenge. The Gold Coast Marathon is held annually on the first weekend in July and is a must-do event for any budding athlete, weekend warrior, or family looking for a challenge to complete together. Run for the good times at the Gold Coast Marathon. Visit goldcoastmarathon.com.au for more information. Today's episode is also brought to you by Pogo Physio. We exist to help you get back to your physical best following injury. We want everyone who walks through the doors of Pogo Physio to cross their physio finish line. That's where we high-five you, tell you that you finished rehabilitation, and celebrate you being back to your physical best. In addition to traditional session-to-session appointments, we offer some industry-first models of care, including our unique 2, 6 and 12-week fixed-fee unlimited access finish line programs and our very popular monthly fixed-fee wellness booster packages, all designed to help you save money and recover faster. To check out Pogo Physio's services or to schedule your initial 1-hour appointment, jump over to pogophysio.com.au. But for now, let's jump back with Dr. Christian Barton on all things kneecap pain. Christian, before we throw into the I guess, deep dive on the treatment, navigating the different approaches to try and, deal with kneecap patellofemoral pain, just two things I think would help lead us into that. One is, I'm often not amazed, but, surprised that clinicians, practitioners, people that, the runners in the community will go and seek treatment from can easily forget that it's the individual that they're treating, not just the sore knee. I often joke that, look, pain's easy to put up with. Most people can put up with a bit of pain in their knee, even as intense as it may get. But it's the psychological impact that tends to bring them in to see a health practitioner, such as a physiotherapist. And I know you closely work with the British Medical Journal and BMJ, and there was a great paper that I recently, it might have been off a tweet of yours, downloaded and read, and it was called The Experience of Living with Patellofemoral Pain, Loss, Confusion and Fear Avoidance, based out of the UK. I'm sure you're familiar with that, but can you just speak to some of the psychological impact that this persistence of anterior knee pain, kneecap pain can actually produce in individuals?
Yeah, certainly. So I think right the way from adolescence, the condition typically prevents people from being as physically active as they would like. We know that physical activity has a lot of health benefits and, in fact, can prevent the development of at least 35 chronic diseases. And one of those chronic diseases is actually problems with mental health and well-being. So if someone's no longer able to stay as physically active as they like, then they sometimes lose that capacity to let off steam, so to speak, but also just do the things they enjoy doing. And that might be going for a run with their friends, that might be playing their sports, it might be as simple as just taking the dog for a walk or playing with their kids or doing some gardening. So as you mentioned, it's not so much the pain that's the biggest problem for people, it's what the pain stops them from being able to do. One of the things we need to be really careful of as clinicians, and I had a great example of this with one of my patients yesterday, and he said to me, he goes, I've seen 5 or 6 physios now and they're all obsessed with the pain. And he said, I don't care about the pain, I'm just concerned that my knee doesn't allow me to run, doesn't allow me to play sport, and now it's actually stopping me being able to just walk and enjoy a nice day. And I think that's really important. So it has a big impact on quality of life. Hopefully that sort of answers your question a little bit. I think a lot of listeners would relate to that.
Yeah, no, absolutely, and I think that's such a key distinction that there's pain, but there's function. It's the function and the loss associated with that, that has that greater impact on people's quality of life and sense of well-being. Christian, this is a topic that we could speak around, particularly with the knowledge that you hold, for hours. We're going to try and condense it into some meaningful stuff, but treating and overcoming anterior knee pain, kneecap pain, patellofemoral pain. Obviously, you're heavily involved with the consensus statements that come out of the literature, every couple of years there, which help clinicians digest what the current best thinking is in approaching the treatment of these individuals with kneecap pain. But clinically, professionally, what are the key things that make a big difference? And we'll talk about the things that don't tend to make a difference. So what would be the top 3 treatment approaches to patellofemoral pain, Christian?
So I think the number one thing that we need to get right is education. And the interesting point about that is when you look at all of the research is we don't actually have any clinical trials or research that's even evaluated the effectiveness or efficacy of education and how that might improve someone's pain, or importantly, as we're just discussing, their quality of life and the way they manage the condition. And in terms of that, we have no research in terms of how we can develop these educational interventions more appropriately. So when I talk about education, one of the first things is just managing loads. As we mentioned before, we typically see an increase or a spike in pain development in people who become really active really quickly, so they're doing too much too soon. And if we don't address that factor, then it doesn't really matter what else we do with these individuals. They're going to struggle to improve. As well as education about load management, we also need to educate patients about potential reasons why they have pain. And I've already mentioned the lack of relationship between MRI findings and X-ray findings and pain. And a lot of patients have this belief, because they've been told by other health practitioners that their knee joint stuff and they've got wear and tear and they've got all these problems. And we often need to spend, at least in my clinical setting, the first 10 or 15 minutes kind of debunking some of these myths that if you've got some cartilage lesions or cartilage things reported on an X-ray and MRI, that's the reason that you've got pain. It's actually not the case. And why that's important to get across to a patient is that we want to stop patients trying to manage their condition based on structure, because if they start trying to manage their condition based on the structure of their joint, they end up in a surgeon's office and end up having surgery, and that will typically not help them. And in fact, surgery in itself is a trauma and can often make their condition much, much worse. And then the other thing we need to be careful and make sure we really educate patients well is, well, not just that surgery is not effective, but what are their treatment options? We can't just tell them we can't have surgery or injections are unlikely to help. We need to educate them about their treatment options around load management principles, which I've mentioned, but also the fact that exercise might be helpful to them, particularly if they've had long-standing pain and there's some muscle function deficits. We can trial things like patellotaping, which has really strong evidence that it is effective in the short term. So in the immediate term, we can reduce pain. And simple interventions like an off-the-shelf foot orthoses, so not having to spend hundreds and hundreds of dollars on these things, but just an inexpensive pair of foot orthoses might also help them in the short term. So giving them understanding about treatment options and the importance of them taking active management in their condition, and that things like massage or ultrasound or other manual therapy techniques, which are commonly provided to these patients, are actually not going to help them in the longer term, and they need to take ownership from it from a load management perspective, exercise perspective, etc.
And Christian, that's great. In terms of the load management, the first point of those three, the education, can you give us some practical examples around, say, a runner that's running every day that's had persistent, kneecap pain? Are there any rules or sort of, obviously it's always individualised to their goals and, their background and everything else, but just generally speaking, do you have any load management rules that you tend to put into practice with the patients that you treat?
Yeah, so typically, and the runners typically run 10 kilometres as their long run, and then maybe they've done 2 or 3 or 4 kilometre runs each week, and they go to the pub and they have a couple of beers with someone and they make a bet, I can do a marathon, and then they don't give themselves enough time and they rapidly increase their training volumes and they develop pain. So the first thing we need to do is bring them back under their envelope of function, so how much load they can actually tolerate without pain. And that's not always easy to predict. We might need to reduce their training volumes by half. We might need to not worry about volume so much, but reduce their speed. Or we might need to look at taking them away from hills. So the common thing I'll tell patients to avoid doing is things like running down hills or running down stairs. Might in the very short term ask them to slow down a fraction. Other way we can manage loads of the joint might be to change their gait or change their running mechanics in the short term and potentially long term. And then what I like to do, so I know that the patient is managing their loads well and they're actually operating inside their envelope of function, would be that they don't have any flare-up of their pain the following day after a run. So they might be allowed to have mild pain during the run that doesn't worsen, but the next day they get up and their pain or their condition is actually no worse than it was the day before. And if they're following that and we get them to that happy level, then from there we can gradually reintroduce more running volume or reintroduce more speed and gradually reintroduce things like running downhill.
And practically they get up out of bed that morning after their previous day's activity. Christian, would you instruct the patient, the client, the individual to do anything particular to test it, like a few little single leg squats or hopping or a little bit of a trot, or to see how it feels just on going about normal activities of life?
Most of the time you can just use normal activities that they normally do each day. And so they might have stairs at home, for example, and they walk down the stairs and they always feel their pain just slightly. So maybe it's a 1 out of 10. And then if they get up the next day and it's still a 1 out of 10, then we're happy and we can carry on. If they get up and it's a 5 out of 10 or even a 3 out of 10, then maybe we're pushing things a little bit too quickly and we might need to reduce running volume or speed or maybe stay away from those hills again. But if they don't have typically those symptoms and it's other things, you might find a task like a single leg squat or a hop or even just actually their next run. So if, say, they have a 1 out of 10 pain when they start running and and they run, and then they want to run consecutive days again, and they run the second day in a row, but when they start their next run, they've got a 3 out of 10 pain, then they probably need to not do that run and give it a miss. And it's not so much time-based when you're trying to manage this condition. It really needs to be what we call criteria-based, and just making sure they're ticking boxes related to pain and ticking boxes related to progression.
Yeah, no, fantastic. Exercise-wise, Christian, obviously it's a big topic, but there is solid evidence there that this makes a difference, and even just clinically, obviously it makes sense. What are the muscle groups, or what are the main aims of exercise intervention, Christian, say in the early stage of treatment and then through to the latter stages?
Yeah, so exercise is a bit of a black box in this area, in that we have really great evidence in at least 38 clinical trials, most of which are good quality trials that would say that exercise helps people with patellofemoral pain. We recently did an audit of this literature, not to see if there was evidence that exercise was helpful, but to see what types of exercise was most helpful. And one of the problems we had with the research is we couldn't actually replicate any of the exercise interventions that were reported to be effective for patients in clinical trials. So that's a bit of a challenge in itself. One of the things that we can see from the evidence is that certainly doing exercises that target the knee musculature or target the hip musculature seem to be effective. And one of the things that we always need to consider as clinicians is patients have limited time sometimes, and also have limited capacity to learn new things. So if we start trying to give them 5 or 10 exercises, there's very little chance they're going to do all those exercises well, or very little chance they actually have the time to do all those exercises. So the question then is, if we know that the hip exercises, or if we know that knee exercises are going to be effective, where should we start? One of the things that we can see from limited research findings is if there's a targeted or more a specific approach at the hip as opposed to the knee, then that's more likely to produce better outcomes for both pain and function in the short term, so in the first few months of doing rehabilitation. So I would suggest that both clinicians and patients typically start around doing hip-based exercises. Why is that the case? Why is it likely to be more effective? Well, if we think about a runner or any patient with patellofemoral pain who turns up to your clinic, they're going to probably have been overloading that knee joint, and they've currently got pain. And if we give them more exercises for the knee to try and address maybe muscle strength deficits, they're actually going to add more load to that knee. So we're probably going to flare their symptoms up even further. So I think a better target is the hip. And then the question is, well, do we do exercises that target muscle activation and muscle patterning? Do we target strength, or do we target power? And I think that's where it comes down to treating the patient in front of you, because we have lots of research that suggests that there's muscle function deficits and maybe delayed or impaired activation of the gluteal muscles, for example. We have lots of research that suggests that people have weakness of their hips and also quadriceps. And we also have some emerging evidence particularly from our group, that would suggest that there's a loss of power in the muscle. So not just the ability to generate force, but the ability to generate force really quickly at both the hip and the knee. So I think we need to consider addressing all of those things. And if we work out where we want to start, if someone doesn't have good motor control or good muscle function, and we try and address power from the very beginning, there's a very good chance they're going to do those exercises poorly, and there's a very good chance they're going to flare their symptoms. So we probably need to make sure we tick that box first, followed by gaining some strength and some basic ability to generate force in the muscles. And then later down the track, as we get towards end stage rehabilitation, we would try and target more so the power or the ability to generate force quickly.
Oh, that's great. And Christian, I think I've found clinically that it's important with the hip musculature work to not just work the obvious glute max, but also, the side stuff, glute medius, the deep hip rotators. And I think sometimes they can kind of be a little bit forgotten, particularly the deep hip external rotators. Is there a bit of a compelling body of work there that supports working those deep hip external rotators, Christian?
So I would suggest not necessarily. I think we do see some research that would indicate if we think the mechanical model is a reason they've got pain and they've got say, patellar maltracking, for example, that internal rotation of the hip will play a big role in that. We see a few studies that suggest that a hip adduction or collapse of the hip inwards and internal rotation or rotation inwards of the hip seems to be linked and associated with people with pain. It's less clear whether those things are the reason they develop pain in the first place. So you can try and target individual muscles, but it's probably not likely to be that effective. But I think your point about not just focusing on one muscle or one movement is really important. And typically what we need to do is make sure that someone has the capacity to absorb load throughout the entire hip, and making sure that their hip abductors, or the muscles that stop their pelvis from dropping and the hip collapsing inwards, but also their hip rotators, so the muscles that stop the hip from rolling inwards, are stronger. But you can target those muscles without doing specific rotation exercises. So I used to do a lot of it clinically, whereas typically these days we can find some really good changes in rotation control during running, and most importantly, the pain gets better by focusing more just on simpler movements like doing hip abduction and hip extension to target the bigger muscles.
Christian, it's like asking to choose your favourite children, but are there any really key favourites you've got that, say early stage work that you just know get results? As you say, patients, people suffering this are often short on time, and don't have the ability to do 10 exercises a day. So have you got any really quick go-to exercises that you like to see involved for the hip and, say, the quadriceps, the quads?
Yeah, so definitely talk about the hip, and as I mentioned, a lot of times we need to start with getting right motor patterning with these people, and to get the right motor patterning, it's very hard to do that by starting with weight-bearing exercises or standing-based exercises. And there's a lot of people out there who are really obsessed with every exercise has to be functional, and that's definitely not the case. If you've got an isolated deficit of your hip or your gluteal muscles, then the best way to actually address that is to do more isolated exercise and do it without standing. So in the early stages, sometimes starting off doing an exercise where you're laying on your side and you're doing some leg lifts up towards the roof, and possibly also focusing on not just lifting up, but lifting backwards a little bit, and ensuring you're getting gluteal muscle activation is really important. And then once you've got good activation, it's then making sure you load that up. And you can do that by adding ankle weights to some extent, but often using TheraBands or resistance bands can be really helpful. And you can start off with your yellow and really light TheraBands, working through to red and then green, blue, black, which is what a lot of people do, but I actually have silver and gold TheraBands in my clinic, because I think if you're going to address big muscle strength deficits, you need to have pretty heavy resistance, and you can achieve that with those types of TheraBands. And then if you want to be really mean to your patients, you can actually just get an old bike tire tube, and that can add even more resistance again. And the other reason I like that exercise is we can also then progress that to addressing the muscle power of the gluteal muscles, and you can start to work on not just loaded movements with that, but rapid movements with that. So that's one exercise I start my patients on, focus on neuromotor and work all the way through to power, and they might typically do that for 4 or 6 months or sometimes 12 months if they've got a lot of weakness. The second exercise, which is a nice simple one that patients tend to manage really well at home all the way through their rehab, is to do a bridge to target more of the posterior or the back of the glute muscles. So we might start with 2 legs, again making sure we get the right muscle functioning and making sure we're using our gluteal muscles, progress that to 1, and then we can add load to that by putting weights or dumbbells or kettlebells or even a medicine ball on the pelvis to add a bit more load to it on 1 leg. And then we can start to work on power as well and try and work on more rapid movements with that exercise. So I don't like to change exercises for my patients all the time. I think it's better to stick to a couple of simple things and then progress them based on exercise principles. But equally, I mentioned that we shouldn't be too focused on weight bearing. At some point, we can also then progress some of those exercises to doing weight bearing and using resistance bands and cables to do some hip strength work. So that's something I'll typically do after a few weeks with my patients. And again, we can work on strength and power with those as well. If we look at the quadriceps, I actually steer clear of squatting a lot in my patients with patellofemoral pain in the first month or 2. And one of the main reasons for that is they typically have really poor hip control and really poor hip muscle function. And if we get them squatting, they'll often load up their patellofemoral joint or their kneecap a lot more, and it can stir their pain up. So I won't do a lot of knee exercise at all in the first few weeks. And when I start, I'll typically start doing exercises like a leg extension, which a lot of people, both patients and clinicians, are fearful of, because if you get it wrong, you can flare their symptoms. But the key things about doing a leg extension exercise are that it can target your quadricep strength more specifically than doing something like a squat. And if you get it right, it works really, really well. So the key things you need to stay away from are making sure you don't work that exercise full into fully straightening your knee or full extension. So make sure that you steer clear of the last 30 degrees of the movement to your knee coming straight. And if you want to target more of the inner quads, so I'm not talking about trying to use VMO biofeedback, which a lot of people have been taught and waste a lot of time on, but also just getting the inner quads a little bit stronger. You can also roll your knee out a little bit, and that can target that a little bit better. So they're probably the most common exercises I would go to all the way through rehab.
That's brilliant. And Christian, exercise prescription, like sets and reps, like what might you start a patient with in terms of reps and sets?
That's a really good question, and it's something that not just patients have a poor understanding of, but actually a lot of clinicians have a poor understanding of, and it's not taught very well at most universities around the world. But if we follow principles of exercise prescription, and there's a lot of research in this area, at the beginning, it's more so targeting the endurance of the muscle and getting the motor patterns right. And it's not so much about the number of repetitions that someone might do, but it's actually the time the muscle's working for. So a term we call time under tension. And what I'll often ask my patients to do is to not focus on the number they do, but making sure they get to, say, 1 minute of the muscle actually working. So that's their key focus at the beginning, and they might do 3 repetitions of that at 1 minute. So they might be doing the leg lift exercise I mentioned before, and they do 3 sets of 1 minute. And if they're really struggling, they can just do 1 minute hold, just holding the leg up in the air, so they get the gluteal muscles to work. And then if we progress that then into thinking about strength training, then we continue to increase the load. So we might add the resistance band, for example, and instead of focusing so much on time, we start to add in some repetitions to that. And a strength training prescription that would lead to growing a bigger muscle, or what we call muscle hypertrophy, would be typically 3 sets of between 8 and 12, but they're very slow movements, and those slow movements of 3 or 4 seconds. So if we talk about how long the muscle is working for, it's going to be 30 to 45 seconds. And then if we go to power and trying to generate that capacity of the muscle to generate that force really quickly, then we actually reduce the number of repetitions further, and we would go to repetitions of around 6 to 8, and we might do 6 sets of that. So the key thing there is it might not be as high a load as when you're doing strength, but the focus is more so on the speed of the movement, so making sure you can generate that really quickly. And if we talk about the running specific population, that's incredibly important, because when our foot strikes the ground, it's going to be in contact with the ground on average for most runners, or recreational runners like myself, for about 0.3 of a second. And that means we've got about 0.1 or 0.15 of a second to absorb the load. So it's no good just being strong. We have to be able to generate that force really, really quickly. And then the final consideration is not just moving through those different types of exercises, but making sure that you have adequate recovery time. So when I talk about recovery time, I'm talking about within each exercise session, and then also after each exercise session. So the recovery time for doing more of a neuromotor or motor control exercise, where we're focused more on endurance, is actually 30 to 90 seconds, and you're recovered, and you can do another set or another lot of exercises. Once you get to strength, you need to have at least 2 or 3 minutes break between exercises. And if you're working on power, you should really have 3 to 5 minutes break between exercises. And that's where a lot of people go wrong when they're trying to progress their exercises towards the end stage rehab. They don't have enough break time between them. And then in terms of recovery time, between days, so after you've done the exercise, you want to have at least 48 hours recovery time after you've done strength type exercises or power type exercises. But if you're doing more of your neuromotor endurance exercises in the beginning of rehab, you can actually do those exercises every day. And I think that's, again, an important thing to differentiate and distinguish.
Christian, well, there's a whole lot there, and that's absolutely excellent information. So thank you for so openly sharing that. You must see clinically that, particularly in that early stage intervention, patients can get really quick wins with the neuromotor work if they do get in and really apply themselves consistently versus a more of a haphazard approach. Do you see that?
Yeah, no, for sure. And I typically tell my patients at that level, for the first couple of weeks, you can make really big improvements if you do these exercises on a daily basis. And in fact, if you do them more than once a day, you might make even faster gains. So I think that's really important. But the other important thing to tell patients about that is you don't have to do them every day forever. And in fact, once we get to that strength and power, it's not ideal to do them every day. And that makes things a bit more feasible for them.
Yeah, absolutely. More digestible, and it gives them a vision of what to expect. Christian, we've spoken about load management, education, exercise intervention. You touched briefly on running mechanics and the role of potential running retraining or gait retraining, both in the short term and the long term. Can you let us into some of the key evidence-based, things that runners can do with their running gait in the hands of a suitable professional?
Yeah, sure. So I think it's quite a controversial area, and most areas with very little research evidence are always controversial because it means expert opinion takes over a little bit more. If we look at the research evidence, firstly, we have a couple of smaller studies that have recruited female populations with a lot of what we call hip adduction or that knee valgus collapse, and they've used running retraining or what really is just run coaching to treat them and give them cues to reduce that hip adduction, and they see some really good outcomes in terms of pain. One of the limitations of that research of focusing on hip adduction and knee valgus is that the patients they've recruited are actually quite unique in that they're the ones on the really excessive end, and they typically would screen maybe 150 patients in order to get 10. So it's not going to apply to many people, but that's one approach from a run technique perspective where someone might ask them to open their knees or use a mirror feedback to help, and that can be really effective. There's been a lot of research in biomechanical studies. So biomechanical studies being studies that look at the outcomes of an intervention on things like ground reaction force and the loads that go through the knee and how it might change muscle function or how it might change the way someone moves. And a lot of these biomechanical studies have looked at step rate. And what it shows is that if we can increase our step rate, or a lot of runners refer to as cadence, by around 5 to 10%, then that can have a significant reduction on the amount of loads going through the knee. So in the order, if we get 10% increase in step rate, so if let's say from 160 to 175, 176, we would likely get around 20% less loads on the knee. And that's not just per step, that's actually accumulative loads. And that's really important, and it's probably driven by the fact that when most people increase their step rate, as long as they don't run faster, they actually land closer under their hips or under their center of mass. So that's a strategy that can be really effective. If we look at a more recent randomized trial, though, when that was combined with something like just good education on load management, it didn't add a lot of value to improving someone's symptoms. But as a standalone treatment, we have some data, and there's some more studies coming out that would suggest that you might reduce your pain on average from 7 out of 10 to a 3 out of 10 by using that intervention. But the key thing is some people will become pain-free and other people will get minimal improvement. But it's a safe intervention that you could easily try from a running mechanics perspective. The other common one that's studied is looking at strike pattern. So not everyone runs with a heel strike, but most runners will. Even if they tell you they run with a forefoot strike, a lot of people have poor perceptions about what their foot's doing when it hits the ground. And if you change from that heel strike to a more forefoot or midfoot strike, that's another strategy that's been shown to reduce load on the patellofemoral joint and on the knee. And there's a really small study which had a control group where they didn't do any retraining of their technique, and the other group did some retraining where they changed their strike pattern, and that seemed to lead to better outcomes in terms of pain. So that's something else that's been researched and there's a bit of evidence for. But then there's a whole heap of other types of running retraining interventions which I use a lot clinically, despite the fact they haven't been researched. And these are particularly taught by a lot of really good run coaches around positioning of pelvis and your trunk and spine, and maybe working on the way in which your leg moves during swing. And some of these things can also be really effective with reducing pain as well. So there's a lot of different options we have, and a lot of times it's about trial and error to see which is the most effective.
And I think it's worth mentioning that obviously, typically in a clinic sense, these won't be in isolation. They'll be combined with some exercise intervention, and it's not a clinical trial that are running in a private practice. So that's great, Christian. Just briefly, you mentioned orthotics. Off the shelf, people don't necessarily need to go and invest hundreds of dollars in a custom-made orthosis or orthotic. Are we talking short-term use here, or is this something that someone with persistent kneecap pain might adopt and run with ongoing? What's been your experience?
Just before I go back to orthotics, I just want to circle back to one really important thing for listeners about running technique, because you'll get a lot of different opinions from people. Whenever you're considering changing your running technique, I like to put different options into categories, and I use a concept of risk, which is an acronym which basically means your options are to reduce load, which is the R, improve capacity, which is the I, or shift load, which is the S, and then the K stands for keep adapting to what that person's capacity and goals are. And the reason I mentioned that, I mentioned a few options there, one of which was step rate, and what that typically does is reduce your overall load, and that's a safe option to use. And if you do things like reduce overall load by reducing running volume and speed or avoiding downhills, that's again going to be a safe option, not likely to cause any other problems. If you think about improving capacity, that's when we bring in exercise therapy and exercise programs, and also just gradually increasing your running volumes. And then the really important thing for us to consider from a running technique perspective is the S, and that means shifting load. So if you change your strike pattern, for example, that doesn't make load magically disappear. In fact, it actually will just shift load away from your knee, and it's going to put it towards the foot and ankle. So one of the really important things for listeners to remember, and a lot of them will get advice to change their strike pattern, is it can be a dangerous intervention to do as well. So just wanted to highlight that before we go ahead, because we don't want people to try and help fix their knee pain by changing strike pattern and end up with a foot and ankle problem or an Achilles problem. So or stress fractures when we see it really badly. So sorry, I just wanted to circle back to that.
No, look, Christian, I think that's wise and pertinent advice, and certainly I've always found that focusing on step rate before foot positioning tends to, I find, take care of the other one anyway in many ways. So that's a good flag. Thanks so much, Christian. And just on that, in terms of time, if people have expectations about changing these motor patterns, their ways of running that have been ingrained for years, in your clinical experience and also your research base, what are some realistic sort of time-based outcomes that people could expect to see, positive and meaningful change around, step rate, for example?
Yeah, so firstly, I guess one of the perceptions from some people is you can't change the way you run and it's inherent of what you do, but that's definitely not the truth. I liken it to, say, trying to improve your golf swing. I'm a terrible golfer, and if I try and play with my friends, then I probably should go and get some lessons, and I know if I did that, I could probably improve it. Specifically for something like step rate, that's often an easy thing to change, and some people might do it if they've got appropriate underlying muscle function. They might do it within a couple of weeks. They might find it natural for them to do. And the retraining studies have been done have typically shown that they can make a new running pattern habitual within a couple of weeks if it's practiced very regularly during that couple of weeks. So that can be as short as that. Other people, depending how much you want to change things, it might actually take them a number of months. And strike pattern's a good example of that, because it might take your calf and might take your foot and ankle a long time to adapt and be able to do that. And what I always think about with changing running technique is, if it's difficult for someone to do, why is it difficult? And it'll usually be because they don't have the underlying muscle function to do it. So I'd rarely try and change running technique without also bringing in some exercises to aid in that. And if they're having difficulty in changing step rate or changing the way their hips move or changing the way their pelvis and trunk move, we're probably going to need to give them some exercises as well to make those changes a little bit easier to do. So anywhere between 2 weeks, and it might take 6 months. But typical patient in clinical experience to make really good changes would be anywhere between 1 and 3 months.
You're listening to Dr Christian Barton on an expert edition of the Physical Performance Show, share around all things patellofemoral or kneecap pain. If you missed last week's episode featuring triple Olympic medalist Andrew Lauderstein, then be sure to jump back and tune in to Andrew's sharings. It's been a super popular episode off the back of the prior guest being Stephanie Rice, who, just like Andrew, took out 3 gold medals in the Beijing 2008 Olympic Games. Andrew shared around the highs, the lows, and the learnings of his career including a great story about coming up against the mighty Michael Phelps in the 100 fly final. To tune into the full episode and explore the archives of the show, be sure to jump over to pogophysio.com.au or peruse the archives from your favourite podcast player. But for now, let's jump back with Dr Christian Barton on this, an expert edition of the Physical Performance Show. Brought to you by the Gold Coast Marathon and Pogo Physio. Christian, the role of foot orthoses or orthotics, just briefly there, what I tend to observe a lot of runners put an overemphasis initially on what shoes they've got on their feet and what their feet are doing, forgetting how they move as a runner and, their capacity, as you say, to deal with the forces, strength and control-wise. But, what have you learnt through your clinical experience, your research base there around the role of foot orthotics? Foot orthoses and shoes.
So I think we need to touch on two things, one being foot orthoses or orthotics and the other being shoes. So let's start with foot orthotics. This is a PhD topic of mine. I spent 3.5 years researching it, and what's really interesting is that there's great evidence for someone with kneecap pain or patellofemoral pain that if you give them a prefabricated pair of orthoses, so a pair off the shelf, that they're likely to benefit from those. And we use statistical calculation in research called number needed to treat. And what that tells us is if we give an intervention to a certain number of people, how many do we need to give it to before we can say it's definitely led to one more optimal or better outcome. And the statistic for that for foot orthoses, which if they're bought off the shelf and then charged to a patient, might be between $70 and $150. If they're off the shelf, would be between $2 and $4. So they're a pretty inexpensive intervention that can be really helpful. But the important thing there is actually that research is based on a population who are not necessarily runners. And in fact, a lot of these people are having pain with standing and walking and stairs and those types of things. We have very little research on the effectiveness of orthotics in a running specific population. There was one study published just recently by one of the authors who also did the big randomized trials that showed foot orthoses were effective in the general population. And this study compared foot orthoses to a gait retraining intervention or changing running technique in a running specific population. It's a very small study and there's a few limitations to it. But what it tells us is the gait retraining intervention seemed to be really helpful, but the orthoses intervention or the foot orthotics intervention didn't really help this group of runners or this small group of runners. And that probably fits with my anecdotal experience or clinical experience in that an orthotic for someone who's got running related knee pain or running related kneecap pain is probably not going to help them very much, but if they've got their pain with standing and walking and stairs, it might help them. So I'd typically tell my patients to use orthotics for those less dynamic tasks if they're on their feet for a long time, but for running I don't tend to go down that pathway. And then if we talk about footwear, which can be really, really controversial, we have minimalist shoes, we have maximalist shoes, we have hockers, we have all sorts of varying types of shoes and recommendations. Then one of the key things that we typically see if we compare the different types of shoes is that the heavier the shoe is and the bulkier the shoe is. So when I talk about bulk, I'm talking about the stack height. So not just the thickness of the or the difference in thickness between the heel and the forefoot, but the thickness of the shoe all the way through, which means you're going to have a thick heel. Then those two elements, thick shoe and heavy shoe, means that we run with a slower step rate. We also run and we end up with higher joint loading through our knee and our patellofemoral joint. So theoretically, we're more likely to have stress and pain on our patellofemoral joint with a bulkier shoe, which are traditionally your motion control shoes that have been prescribed and sold to people to help their knee pain. Anecdotally, I'll find that if we can try and reduce the bulk of the shoe and reduce the weight of the shoe, that can be something that can help improve their running mechanics and also help with their pain. So if we go towards a more minimalist shoe, that can be a really effective intervention for people with knee pain. But what we have to be really mindful of, and I'll go back to that whole risk concept, is when we change to a less bulky shoe or a more minimalist shoe, that will typically shift load to the foot and ankle as well. So we need to be really careful that we don't then cause another injury as a result of making those changes. And this is what creates a controversy in that people do really well if they go to a minimalist shoe or do barefoot running and their knee pain gets much better and they have no additional problems. And then another person does the same thing and their knee might get better, but they end up with a stress fracture in their foot. And so it's really up to the individual, and we end up with these controversial topics and debates. And one camp says that we have to go barefoot and throw our shoes in the bin, and the other camp says, no, we need to stick to our motion control shoes. So the truth's somewhere in the middle.
Yeah, I think that's well articulated, Christian. Certainly I've experienced with my patellofemoral pain over the years that going to a less bulky shoe, having a quick, turnover rate, has helped enormously. And so, but as you say, it has to be done with wisdom, considering the risk profile for other potential things, Achilles tendons, stress injuries of the bone, etc. Christian, in terms of taping, you mentioned that briefly at the start. This can be the K tape, the kinesio tape. Would you typically see that as a short-term intervention to help an individual deal with their pain before they build that capacity in their body to absorb load and mitigate symptoms that way? Or would you potentially see this being used throughout someone's condition and rehabilitation as long as necessary?
Yeah, so tape can be controversial as well. And when we look at the evidence for taping, there's some systematic reviews. So this is a summary of all the evidence that would say that taping doesn't work. And then there's some other systematic reviews, which is summary of all the evidence, which is exactly the same evidence, and that says that taping does work. And the key differentiation between those reviews is the reviews that say it doesn't work will combine findings from a couple of weeks after people started doing taping to a year after people started doing taping. So if you break it down, it shows us that if you use taping of the kneecap, that you can actually have a really big improvement in pain in the immediate term, and possibly improvement in pain in the short term, so up to the first 4 weeks, if you combine it with exercise compared to exercise by itself. So people seem to get better a bit faster. So I think it's really just a short-term intervention to help facilitate exercise rehab. If you were to just tape the knee and do nothing else, I don't think that's a very sensible approach, because you're probably not going to address the underlying causes and deficits, and that could be the load management side of things we've talked about, or it could be the muscle function deficits, and we might need to ensure that we do those things. The other thing I'll point out about taping is we have this brown tape, which is rigid and not very stretchy and looks a little bit ugly. And then we have this fluoro tape that's called kinesio tape or rock tape, and it's bright colours and orange and pink and blue. And actually what some people get caught up in is kinesio tape more effective than this brown rigid tape, or actually is the brown rigid tape more effective than kinesio tape? Actually depends on the person doing the taping, and that's the key thing. So it's not what type of tape you're using often, it's how you're actually taping the joint. And there's actually good research to suggest that if you tailor the taping to the individual as opposed to apply the same tape to everyone, that you will have better outcomes. So I think for those listeners out there, seeing someone who has really good knowledge of taping options and getting taught the right taping for them is very sensible to help them manage pain in the short term. And then the other myth that often gets talked about is that taping builds reliance on tape. My anecdotal experience is that's definitely not true. What it does is helps people do their exercise rehab better, maybe manage their pain a little bit better when they're running and training. And as long as they address all the other things that are going on, they inherently just stop taping when it becomes more effort than it's worth. So if it's no longer really helping them anymore, or their pain's better without the tape, they'll just stop taping because they don't need it.
Yeah, great. Christian, as we said at the start, we could speak for hours. Been conscious of time on your end there and your pressing remainder of the day. What would be, in sort of bringing our time to a close today, what would be the top couple of mistakes that you see runners making in dealing with this, and then what would be your top key summary tips to get going in the right direction with kneecap patellofemoral pain? Top mistakes and then top tips.
Yeah, so top mistakes is probably trying to take shortcuts, trying to get injections to manage it, or use painkillers, or trying to look for that quick fix. So that's really important. And as part of that, overtraining is typically the key thing. So you need to listen to your body and try and manage your loads a lot better. And often that means a short-term hit, so reducing your loads in the short term for a long-term gain, so you can continue running for the rest of your life and running hopefully pain-free and getting all the health benefits that running gives you. In terms of tips, if you go and see a therapist for help, don't expect them to do passive, hands-on manual therapy. The key thing that you should be getting from your therapist is actually being coached in how to manage your condition better. So that's guidance and assistance on managing your loads, guidance and assistance on the appropriateness of different exercises that might help you, and making sure they're spending enough time teaching you how to do those exercises really well. And that's really important. And not just teaching the exercises, but then following up with them to progress those exercises so that you can optimize your gains from them. Maybe teaching you some simple things like taping and those things, but that's not necessarily a priority. And I think if you find a clinician who can help you with those two things, that's going to be most important. And then the third thing, beyond load management and the right exercise guidance, would be probably making sure that you're having your running technique checked by someone who knows what they're doing. So this is not the shoe store that's trying to sell you the most expensive pair of shoes, or the podiatrist who wants to put a cast of your foot and give you a really expensive pair of foot orthoses. This is someone who will look at your technique and see if there's any little changes they can make safely to help improve your running mechanics and improve stress on the joint. And if you're really lucky, you might find someone who can also help you at the same time with your running performance in the longer term. So they're probably the three key things. So the education, the exercise, and then also considering the way in which you're running, and probably in that order.
Brilliant. Christian, if listeners want to find out more or seek out your services, where's the best place for listeners to go?
Yeah, so probably two things to flag. One is obviously I work clinically, so I'm in Melbourne at a clinic called Complete Sports Care, based in Hawthorn. As I said, see a lot of runners, but my big passion and what I hope this might inspire some people to engage with is a not-for-profit initiative that I've set up for trying to get good quality information to clinicians and to patients, and that's called TREC. We have a website we've just launched, and that's trekeducation.org, and we actually are building websites currently for clinicians and patients that will help them manage knee pain more effectively. So if you get on that site, if it's not there already, when you listen to this, it won't be far away. You'll find some online web resources that are a lot more trustworthy than Dr. Google for you to manage your condition, and they'll be free and open access. You won't be asked to pay for them, etc. There will be a donation option if you like what you see and you would like more of that type of information, then you'll certainly be able to donate, but there'll be no obligation for that. We just want to try and get the right information to people.
Brilliant. And we will certainly tag that up in the show notes, listeners, so jump over and look for those links. Christian, two things. One, finally, the physical challenge for the week, but I feel I must ask you, because this is something that the listener listening in with kneecap pain will be trying to wrestle with. Obviously, as physiotherapists, it does technically sit outside of our scope of practice, but medications, anti-inflammatories or analgesics, what are your sort of learnings in terms of medication throughout rehabilitation of this condition?
In a GP setting, when you go and see a general practitioner, overemphasise. You're told to take paracetamol or anti-inflammatories and go home and rest and it'll get better, and that's not true. That's number one. Number two, if you want to use them, maybe you would consider using them if you've got a really important event coming up and you're just not quite managing your pain. You might consider it, but it'd want to be a pretty important event. Otherwise, get the other things right: load management, exercise, education, because the analgesia, the paracetamol and the NSAIDs and other things are not going to help your problem. In fact, they'll probably in the longer term make it worse because you're not listening to your body.
Yeah, brilliant. Christian, physical challenge for the week. What's Dr. Christian Barton's challenge for the week going to be to listeners?
Sure, I've got a slightly unique one for you, and because I'm a clinician, but I'm a very geeky clinician and I like research. This is actually a physical challenge / a screening test for the listeners at home. You need two pieces of equipment. You need a chair, a standard height chair. They're usually around 45 centimetres, so your kitchen chair will probably be fine. And you need a metronome, and there's lots of free metronome apps online, so get a metronome up. Set your metronome at 20 beats per minute, so it means you'll be beating 20 times per minute. And then your job is to cross your arms, and with one leg only, and you can test both sides, you need to stand up and sit down one time to each beat. So you need to do 20 of these in 1 minute without stopping. So one per 3 seconds and 20 in total. Why 20 and why a minute? Well, we have some really good research evidence that would suggest that if you've had knee pain in the past and you can't do 20 of these, then you're likely to develop osteoarthritis in the future, and your likelihood is quite high. So it's a bit of a physical challenge test for you, and if you're really struggling with that, stop doing so much running and go and see someone to get some good exercise and a good exercise program to get a little bit stronger so you're a more resilient runner.
Brilliant. And just to be clear, so that's going from sitting to standing 20 times in a minute on a 3 second count, Christian?
Exactly. Yep.
And if people are symptomatic and that's giving them a little bit of pain through it, so they are, suffering right in the middle of it, should they push through it or stop or get in contact with their local physio?
Probably get in contact with your local physio. Don't if it's a tiny bit of pain and the pain doesn't increase as you go, I probably wouldn't worry too much. But if your pain's increasing as you do it, it's probably a sign to stop and go and see the local physio or someone who can help you with some exercise.
Yeah, no, brilliant.
And some of the listeners, regardless of pain, just won't get there.
So, Dr. Christian Barton, just a leftover question that we didn't get to dialogue when we were together last is something that, often comes up in the treatment room, and certainly any listeners that are suffering from kneecap pain or patellofemoral pain may be wondering, and that is, what's the role of stretching, both in terms of in the clinic that you've seen in your years, but also what does the research tell us about the stretching of things like quadriceps, hamstrings or calves as an example?
Yeah, it's a good question. I think if we talk about research first, there's not really a lot of evidence that would suggest that doing a stretching program is going to help you much in the longer term. Certainly patients anecdotally will report stretching the hamstrings or stretching the quadriceps or the calf can be helpful. I think some patients will report stretching the quadriceps sometimes irritates their symptoms as well, so you need to be a little bit cautious with that. I think if we consider why you might stretch your muscle, it's because it feels tight and that might help you relieve the symptoms. But the question is, why is the muscle tight in the first place? And typically a muscle is going to tighten up because it's being overworked to what its actual capacity is. So I think what we need to work out for each person is what the reason it's being overworked is, and that could be one of two reasons if we keep it really simple. It might be that muscle is being overloaded because other muscles in the chain are not functioning well. So for example, if we've got tight hamstrings or tight quadriceps, that might be because the hip muscles or gluteals or core muscles are not very strong or not functioning as well as they could, and that means more load onto the hamstrings and quadriceps. Or the secondary part, and sometimes they're in combination, might be that those muscles are actually weak and too weak for what you're asking them to do. So if you are trying to run at speed, for example, that takes a lot of hamstring muscle power, and if you're asking a weak hamstring to do that, it's probably going to get tight. It's probably not going to get happy with you, and we know that a tight hamstring, for example, can increase your stress on your patellofemoral joint. There's a few running studies and modelling studies in a research lab that show that. So I think get to the root cause of why it's tight in the first place, rather than trying to just stretch it all the time.
Yeah, and it's just going to give you a better return on your time and energy, plus actually, solve the underlying contributing factors to some of the kneecap pain, not just temporarily make it feel better.
Yeah, exactly. And I think a lot of people who are runners will relate to spending a lot of time on a painful foam roller, doing spiky balls and all of those sorts of things. And I reckon they just need to maybe investigate a little bit more carefully themselves, or with a good physio or a good health professional, as to why the muscle's tight in the first place. Get to the root cause of it, get some other areas stronger or get those muscles stronger, and they probably have to they can stop going through that torturous process.
So less stretching, and would you advocate, obviously it's on a case-by-case basis, that some people do need to continue to stretch to some degree with patellofemoral pain, or it's just completely individual, Christian?
Oh, it's really individual, and a lot of patients I'll see, they may be doing stretching and they're helping. Others will be doing stretching and they tell me it doesn't help, so I tell them not to waste their time, just do some more strength work. In most cases, if it is helping them, in the short term, I encourage them to continue doing it. In some cases, I will prescribe some stretching exercise in the short term, but if they can spend long enough at doing a strength program, maybe a 6 or 12-week period, typically if they do that well, then the need for stretching is gone.
And what might you prescribe, Christian, like a hamstring stretch or a quad stretch or what?
Yeah, so typically there's a few things that can be quite helpful for someone with patellofemoral pain. Hamstrings can be a really key one, so just doing simple static hamstring stretches will sometimes relieve symptoms in the short term. The other one, which most runners will relate to, is hip flexors. If you've got a lot of tightness through your hip flexors, it does seem to be a lot harder to get gluteal muscle activation, and we know that that's quite important for taking stress away from our patellofemoral joint. So if you can try and stretch out your hip flexors a little bit, that can make a really big difference. And you can do that through standing lunge type stretches, or your more traditional one with your knee on the ground. And then the other areas, sometimes calf stretching can help. The the mechanism of why that helps is a little bit less clear, but can definitely help. Or quadriceps, but you do need to be a little bit cautious doing a lot of quadricep stretching because sometimes it just irritates people's symptoms.
The pressure on the kneecap.
Yeah, exactly.
Dr. Christian Barton, very generous of you to share today, and certainly I'm a big fan professionally of all the work you do, the knowledge translation, the research. So thanks for what you do for me professionally, and certainly this is going to be a huge help to listeners out there who are battling away with kneecap pain.
Thanks for having me, Brad. It's been my pleasure.
So there you have it, another episode of the Physical Performance Show. I trust you enjoyed today's episode featuring Dr. Christian Barton, expert edition, focusing on all things kneecap or patellofemoral pain. If you did enjoy this episode, or you know someone that would benefit from Dr. Christian's wisdom on this topic, then be sure to please share the information with your friend or colleague. You can find Dr. Christian Barton easily over online, very active. Dr. Christian's very active on social media, particularly on Twitter. Dr. Barton's handle is at Dr. Chris Barton, Barton. If you did enjoy it, then please let myself and Dr. Christian know what it was that you enjoyed or took away from the episode. You can find me on Twitter or Instagram over at @Brad_beer. If today was your first time tuning in to the Physical Performance Show, then a mighty welcome. If it was your 112th time, then thank you for your ongoing support. Don't forget to hit subscribe if you've been enjoying the episodes each and every week. That will help keep the episodes coming straight to your device as they go live every Thursday evening at 9 p.m. If you've been enjoying this show, then please consider leaving a review on iTunes. It's really simple. You can jump over to your smartphone, simply click iTunes and search for the Physical Performance Show and leave a rating, 1 star to 5 stars, or even better, a review. And if you're not up for leaving a review or a rating, then don't worry, I'll still love you anyway. But if you can leave one, that would be enormously appreciated. It helps this show reach more earbuds of people who, just like you, are looking to pursue and perform at their physical best. So go on, leave a review, and thank you in advance. A big thank you this week to one show listener who has left a review over on iTunes, and that is Run S. Mackley. Run S. Mackley rated the show 5 stars, a brilliant podcast to subscribe to. Brad interviews such a wide variety of athletes and sports professionals that he has me coming back for more each time. I implore you to listen to an interview with someone that you've never heard. Brad plays to his strengths and it shows. Run S. Mackley, thanks very much for taking the time to leave a review. Enormously appreciated. Talking about appreciation, a big thank you to the team who make the Physical Performance Show possible each and every week. That is Susan Wilkin on all things show administration, Matthew Olding on all things graphic design, and Daryl Misson, our amazing audio engineer, who does an incredible job in bringing this to you each and every week. Of course, another big thank you to the show sponsor for this episode, the Gold Coast Marathon. If you are into running or a challenge, then don't miss the Gold Coast Marathon, held on the first weekend in July on the beautiful sunny Gold Coast every year. It's one of my favourite events on the calendar, an incredible atmosphere with an event for everyone looking to be active or to push themselves physically. So jump over and check it out, thegoldcoastmarathon.com.au, who really do help make this podcast possible through their support. If you're looking to run the Gold Coast Marathon this year or any of the events from the 5.7 kilometre event right through to the full marathon, then consider joining the Pogo Physio team. We put a team in every year. We have a whole lot of fun with a whole lot of perks, and it's really simple. Simply drop down and select Pogo Physio as your team and enter the team PIN, Team Pogo, all capitals. We'd love to have you join us and up to 100 other runners at the Gold Coast Marathon this year. We are always looking to get better. So we have created the Physical Performance Show quiz. That's where you can jump over and leave your much needed and much appreciated feedback. What can we do better? with the show. Who would you like to hear from? How often would you like to hear these expert editions, etc.? Take a moment to leave some input via the quiz at pogophysio.com.au/podcast, and you can go into the draw to win a $100 movie voucher to the cinema of your choice, to be drawn on episode 116. So you've got a few more episodes to get your feedback in. A big thanks to everyone who has left some great feedback so far. Don't forget, you can win a signed copy of my Amazon running and jogging bestseller, You Can Run Pain Free, by taking a podsy and sharing it around for the week. That's simple. Take a screenshot of the episode that you're listening to and tag myself in at Brad_beer, and we'll see that, and you're into the draw to win a signed copy of the book. This week's podsy winner was triathlete Renee Killy. Renee shared the episode that she was enjoying, being episode 105, featuring 2016 Olympic triathlon champion Gwen Jorgensen. Thanks for your support, Renee, and also enjoy the book. Signed copy coming your way. Talking about You Can Run Pain Free, stay tuned for the release of the revised and expanded edition of You Can Run Pain Free, available from mid-June in 2018. You Can Run Pain Free first became available in 2014 and quickly became a bestseller. If you are a runner and looking to unlock your true running potential, then consider attending a Run 101 workshop held here at Pogo Physio on the beautiful Gold Coast. The workshop is 6 hours in duration, and you will be led by myself, Brad Beer, fellow physiotherapist Lewis Craig, and also podiatrist Alex B, through an 8-part 6-hour boutique workshop experience. You will benefit from an individual running body screening and assessment, an introduction to gym and strength-based conditioning, individual running gait analysis and recommendations, individual footwear assessment and foot function index assessment, and prescription of the right shoes that will best serve you as a runner and your goals, and a whole lot of fun, all in a 6-hour boutique workshop experience. For more information, jump over to Pogo Physio and drop down on the services tab and check out the Run 101 workshops. Coming up on next week's episode of the Physical Performance Show, I caught up with Cameron Dye. Cam Dye is a Boulder, Colorado born and bred professional triathlete who has made an incredible career and name out of the Olympic distance racing in the US and worldwide scene. Cam and I caught up and spoke about the highs, the lows, and the learnings of his incredible career. He was gearing up for an assault on the escape from Alcatraz triathlon. When we spoke, you'll really enjoy Cam Dye, so be sure to tune in next week to the Physical Performance Show. Until then, keep pursuing your physical best. I'm Brad Beer, and this has been the Physical Performance Show.